Good morning and welcome to Breaking Burnout for Nurses podcast. I'm so excited to have Carolyn Cahn back with us again. Last time we talked, it was about occupational health, and she was in that profession for how long? Occupational health?
I over 40 years.
Over 40 years. So very experienced. She gave us a lot of good information about that. And this time she is joining us to share her thoughts about home health. And many other things. I'm going to have to keep having her back. So today, Carolyn, um, please share a little bit about what you've done with home health and
Mhm.
how you got into it, how you got interested in it, and how we can get into it too.
Okay, so I sort of fell into it. I was working in the emergency room at Children's Hospital, and they offered an opportunity for a special program with pediatrics and home health. So I went through a 1 year training, and then we did a little bit of visiting of children at home as part of the program. And
Okay.
so that was my entree to home health. I wasn't looking for it, it was just part of the program.
Okay.
And then from there, I wound up leaving the emergency room and working for home health full time.
Okay. So what was that? So was that a job or an assignment for a short while, or how did
And so,
that work
so
out?
I actually worked for visiting nurses.
Okay.
That's always been a nonprofit. Sadly, they've been eaten up by a lot of the corporates. But so an independent company, there are tons of hospitals that have home health. So for a nurse who is working in a hospital, I always encourage people to look within the facility to see what other opportunities there are, because some hospitals have their own home health agencies.
Oh,
And
I didn't know that. I thought they were a separate entity. I did home health um, maybe the beginning of my career in the 1980s. I did some home health to kind of just to get a start in nursing, and at that time, from what I understood at that time, it was just a separate agency that would send nurses out to wherever they needed extra help. So I guess now there are more options for nurses.
right, so you have a lot of freestanding companies as well.
Okay.
But if you think about the larger hospitals, I know, let's take Cedar Sinai in LA or Northridge, they're part of big conglomerates now.
Yes.
So oftentimes they had to get into home health because they were losing money to these freestanding places. It's a good revenue for them. So it's always good to take a look at what's in your own company so that you can retain or build up your retirement, because sadly that's not something nurses think about, right? So if you can avoid going from one company to another and get either 5 or 10 year vested, depending
Mhm.
on the facility you're in, I always encourage people, what can you do within where you're at before you leave, just to at least get vested? And that's a
Yeah,
whole other
that's a good
discussion.
idea. There are a lot of opportunities, especially like you said, in a large type of corporate hospital.
Mhm.
Yeah, there are a lot of things that you don't realize that it's not just floor care, or it's not just the big units. There's a lot of other situations that you can learn about. So, one thing I think of is just putting the word out that you're interested in finding something else in the hospital, in your own hospital, because you never know what somebody might know about another unit. Just talking to your friends and just letting them know that you're kind of poking around for, yeah, I'm open for a new place. Not that you don't like the unit that you're in, but open for some new experiences like that. So and there probably are some employee bulletin boards where you can find out some new job openings or opportunities too. So yeah,
And
it's
the other thing would be the nurse recruiter sometimes is a
oh
good person
yes,
to talk to.
Mm-hmm. Yeah. So, okay. So, give me an example of how you would do your home health in your hospital. How does that
So,
work?
so yeah, so what will happen? So, like Kaiser, as an example, has their own home health. But what it is, it's there's an office that's dedicated to home health. So you are then a home health nurse and you're not working in the inpatient anymore.
Oh,
So
okay.
you're specifically working for the home health division. And to clarify, there is home health and hospice. They've separated them as two different services. Sometimes they're both out of the same office, sometimes they're completely independent offices. But home health is usually not the death and dying, whereas hospice is
Mm-hmm.
supporting those with a diagnosis generally of 6 months or less to live. And
Okay.
so you're helping them maintain dignity and independence and keeping them at home through the dying process as much as you can. So it's a lot of education and service, different area. Home health is people come out of the hospital and within 24 hours, the doctor will call a referral in. And so it becomes a question of what's the purpose? Is it a new diabetic? Now you're going in and teaching them how to take insulin and diet. Hypertensive, you're doing blood pressures. There's a lot of wound care. A lot of people come out with fresh wounds and they can't physically do it themselves, either
Mm-hmm.
because of location or because of the type of depth of it. So, we even do wound backs and things like that. You could have people who need chemotherapy. You have people who get different kinds of IV treatment in the home. So it's a variety. Colostomy patients, new colostomy patients, teaching them. So a lot of skills, a lot of education.
Wow. Okay. Now, did you say that they are that your home health is related to case managers or case management, or you kind of work hand in hand with them sometimes, or did you say they weren't connected? I'm sorry. Just
Yeah,
trying to
I didn't.
clarify
Yeah, we
that.
didn't talk about case management relating to home health, um, because case management is usually the inpatient side, getting them out. Home
Okay.
health. So home health, in a way, you're doing case management, but I don't want people to get confused with what a
Mhm.
case manager is, right? So when
Okay.
you go into home health, you are managing a case.
Okay.
It is your patient. You go out, you do an assessment, and you decide, do they need occupational health? I'm sorry. Um, well, it's physical therapy, occupational therapy.
Mm-hmm.
So physical therapy, occupational therapy is more specific. Excuse me. Specific to hands and fingers.
Okay.
Do they need mental health? Do they need a social worker? So you're in there making a total assessment, and then as you're there, you are the case manager for that patient, but it's different than inpatient case management.
Okay. All right. I was getting those confused, so I can see how. Thank you for clarifying that. Let's see. Home. Is there anything else that you wanted to add about home health?
Right. So what happens is you go into the office, or nowadays you can do it from home, and you get cases, and then you map out your day based upon where patients live, and now you're driving to where they are. So the nice thing is you can schedule the clients around your personal needs. So if you're taking classes, or if you have a child, or if you're taking
Oh,
care of someone, you can
yeah.
actually go and schedule around it as long as you get your patients seen in an 8 hour day.
Oh, okay.
Some of them would be happier with you being later. So
Uh-huh.
it's really nice for people that need some kind of an adjustment, because you can run and pick up your kids, like I said.
Yes.
Um, so the good thing is you have that flexibility.
Mm-hmm.
The negative of it, it's wear and tear on your car. So you do get paid
Yes.
mileage, but you just have to realize, based on where you are, it is going to be putting some miles on your car. And the more rural you are, the more miles it is. And if you're
Wow. Yeah.
urban, then you've got traffic issues.
Yes.
The
Yeah.
only other caution would be as you look at what they pay, find out what's covered under that hourly rate. So they pay
Mhm.
based on hourly rate or based on case rate. So I did both. As a case rate, what they'll do is they'll pay you, let's say, $50 for a case.
Okay.
Well, that covers you going in, seeing the client, then doing the paperwork, which is now, of course, all computerized. But
Hmm.
you have to go in. So the question is, how long does it take to do the patient assessment and get all
Hmm.
the paperwork in?
Hmm.
And you need to make sure that you understand what your hourly rate really is. Because if you're making $40 in a hospital or $30 in a hospital, and now you're doing a patient admission and all the paperwork, again, computer work
Hmm.
that's required, if it comes down to 20 hours when you calculate at $20 an hour, then it's not really worth it. So
Right.
if you're doing it at an hourly rate, then you're getting your due diligence, what you're not due diligence, what you're due financially, and it's a fair system. So I just caution people when you look at how they pay, make sure you understand what's covered in that rate.
Yes, because I was just thinking, if you're paid by the or if you're paid by the case, what if your case takes longer? What if it for whatever reason that particular patient needs, a little bit longer time to get everything completed. So then it wouldn't be worth it. But then on the other hand, if you got it done real quick, then you're making a good fee. So yeah,
So yeah,
that's
so the difference is they do open case opens, which is the new patient, the first time you see a
okay.
patient, and that is always going to be a longer visit.
Okay.
Then the follow-ups are shorter. And
Hmm.
then the wound cares are usually pretty quick. So if they give you a combination of opening cases and reruns,
Okay.
then you can make a fair living.
Hmm.
If they only give you 3 open cases in a day and no reruns, then
Hmm.
if you're doing it by case only, you're
Hmm.
not going to make as much money. So you need to really look at that.
Yeah, I mean, you have to strategize, right,
Mhm.
to make sure that it's worth your while to take that assignment. So are you able to kind of pick and choose which ones are acceptable, which cases are acceptable to you, or do they get mad if you don't accept every case that they offer?
Yeah, you don't usually have a choice.
Yeah. So that's pretty tough. And then also, as far as how far you drive, do you get to put a limit on, okay, I'll drive 20 miles, or my limit is 10 miles or something like that? Or then do they just say, okay, well, you don't drive far enough, so we can't give you an assignment?
So it depends on the place that you're working. When I worked, we had areas that we picked for ourselves among the nurses, so it wasn't official.
Oh, okay.
So I could see a patient on my way to work, on my way home.
Oh.
It depends on who you're working for,
Hmm.
and it depends on the nurses that you're working with as to how they're willing to divvy it up. So if you're
Hmm.
a regular employee, some agencies just tell you this is the area we have that's not covered.
Hmm.
Sometimes they'll say we have these cases and then you work together as a group.
Hmm. So what happens if there's some area, like if a patient lives out far and there's no coverage there? What happens to that poor patient? I
And that's
mean,
why they usually an agency won't take somebody that says I'm only willing to drive 10 miles.
okay,
Right.
yeah,
If you put a limit on, it's a geographic limitation more likely.
yeah,
So
okay.
I know in New York City, they actually have to take public transportation to get around to patients because parking is so hard.
Wow, okay. Oh my goodness. Yeah, okay. Well, Carolyn, thank you so much again for being on my show, the Breaking Burnout for Nurses podcast. So a lot of our topics are specifically for burnout survival for nurses. And so a lot of it is just finding the right space in nursing for you. So Carolyn was on another show and talked about occupational health, and then this time sharing her experience with home health. There are so many avenues that you can choose with nursing, of course. So that's one of our great benefits of being a nurse, right? Because there's so many ways that we can go, and I really think that helps us, with our burnout, because there's so many ways, if you're just sick and tired of wherever you are, and you just need a change, that's why I like to have you on to share your different experiences in nursing. So, but we were talking earlier, Carolyn, about, other things besides specifically nursing. And one of them that you said to help with our stress is tapping. And so, that perked my ears up. I have heard about tapping before. So got to have you back on the show. Okay. I'm just telling you, you're going to be on my show again. So anyway, thank you so much for being on this show. And I look forward to having you back, Carolyn. And I just want to throw out there. So right now I'm working on becoming a CE provider, continuing education provider, and it's kind of a process. But so I'm going to be offering CEUs, continuing education for nurses, probably starting in 2026. So keep your ear out for that. And we will see you next Monday again, 10 o'clock Pacific time. So, another thing too, let me stop talking, is if you would like to be on my show and share your nurse burnout survival tactics, please go to my website, breakingburnout.com. Oh, there's Belle. Hi, Belle. Hello. She's camera shy. Anyway, so go to my website, breakingburnout.com, to the podcast tab, and take a look at what it takes to be on my podcast, and just fill out the form and then join us here on the show. So see you next Monday. Bye, everybody.